Over the past decade, cardiac care services have changed dramatically, as have the public's expectations, who expect the NHS to go even further to deliver high-quality, life-saving care. The NHS needs to maintain a momentum in cardiac services by focusing on longer-term management and enabling those who survive coronary events to have access to cardiac rehabilitation services. Over the last 10 years, the NHS has benefited from higher levels of growth in expenditure than at any time in its history, and cardiac services have been substantial beneficiaries. Today, we have to recognise that it's inevitable that the current financial climate is going to have an impact on cardiac services offered by the NHS. This challenge to deliver continuing high-quality care while at the same time delivering it more efficiently is the biggest challenge that has faced the NHS in recent times. In this programme we hear the views of Dr. Christopher Baker, consultant cardiologist at Hammersmith Hospital, London. We also hear from leading heart and cardiovascular innovators,
Boston Scientific and Hanson Medical,
who share their knowledge of working with the NHS and wider healthcare sector in the field of heart and cardiac care.
I think one of the most important recent developments is the development of what are called primary angioplasty services. And these are services that have been set up to treat people who are suffering with acute myocardial infarction, so heart attacks. In the not so distant parts, and still in some parts of the country, patients are treated with clot busting drugs. A lot of hospitals now are setting up angioplasty services, so patients who have heart attacks are brought direct by the London ambulance or the ambulance service to the hospital, where they're treated with angioplasty, which is the balloons and stents. And that's been shown in a number of trials to improve mortality, reduce mortality from myocardial infarction, and to improve outcome. And I think that's been a huge step forward in the treatment of patients with myocardial infarction. Stents are metal mesh tubes that are implanted in arteries. They're used not only in coronary arteries but also in the arteries that supply the brain, the carotid arteries, sometimes in the arteries of the leg. And what was found was that narrowed arteries, arteries due to furring up with cholesterol and inflammation, can be stretched open with a balloon, but they'll quite often re-narrow. And the implantation of a metal mesh tube, a scaffold, tends to reduce the restenosis, the re-narrowing rate, and keep the artery open more reliably.
Coronary artery disease is a build-up of fatty deposits in the coronary arteries. The coronary arteries supply the heart with blood, and therefore any impediment to the blood supply down the coronary arteries starves the heart of blood and prevents the heart functioning appropriately. The build-up is due to fatty deposits in the coronary arteries, and the fatty deposits eventually narrow and can actually block the coronary arteries completely. When the coronary arteries are narrowed, typically a patient would suffer symptoms of chest pain, which is called angina. The symptom of angina occurs when the heart is put under stress. This might be on exertion, with emotion, or in cold weather. And the patient experiences pain, usually in the center of the chest, often rather diffuse, not in a very small area, but in a wide span across the chest. The pain may radiate or move down one or other arm, commonly the left arm. Associated with the pain, the patient will experience nausea, sickness, sweating, may become lightheaded. There are a number of risk factors for coronary artery disease, and they would include smoking, diabetes, high blood pressure, and being overweight or obese. Quite frequently, more than one of those risk factors is present. So a patient may smoke and be overweight and have diabetes. A high cholesterol is another risk factor for coronary artery disease or angina, and there may be no overt signs of a high cholesterol, nothing to show that the patient has high cholesterol, but when the cholesterol is measured in the blood, it's found to be elevated, and if you have high fats in the blood, then these may be deposited in the coronary arteries. The majority of patients with coronary artery disease are treated with angioplasty. This is a routine procedure usually undertaken under local anesthesia and may more frequently these days be undertaken as a day case with the patient only staying in hospital for a few hours. Under local anesthetic, a very fine tube is placed in an artery in the groin or in the wrist, advanced to the heart, pictures taken of the coronary arteries, and then the narrowing, once identified, is stretched up with a balloon. The balloon increases the lumen, or the hole in the artery for the blood to flow, and drives the cholesterol into the wall of the artery, but is often associated with the narrowing coming back. And therefore, once the pathway has been made in the artery with the balloon, a stent, that's a small metallic tube, like a scaffolding tube, is inserted over another balloon and is driven into the wall of the artery to hold the artery open. Even today, coronary artery disease remains the biggest killer in the UK. And this may be unknown to some of you because often cancer gets more publicity than coronary artery disease. And although it affects men disproportionate to women, as women live longer than men, there are still many women who are affected with coronary artery disease. Now, it's true that over the last few years there's been a significant reduction in the number of patients suffering from coronary artery disease, and that is because the causes of coronary artery disease, the risk factors for coronary artery disease, are more readily identified and being treated earlier. What's clear, however, is that a proportion of the population is really getting the message. They're keeping their weight down, they're exercising, they're controlling their cholesterol and blood pressure, but another proportion of the population are not getting the message. They continue to eat the wrong things, they continue to smoke, and they develop diabetes. So although overall in the country coronary artery disease is improving in terms of the number of patients, there are still groups of patients in the UK who have a very high prevalence of coronary artery disease. Over the last few years, there's been a lot of focus on the delivery of minimally invasive techniques so that patients can come into hospital, sometimes only for a few hours, and be treated effectively with coronary stents in a way that allows them to get back to work promptly and avoids the need for a big operation.
What is valvular heart disease? Well, the heart is a muscular pump at the end of the day, and there are a number of valves in the heart, 4 in fact. The valves allow blood into a chamber or out of a chamber, and they basically allow blood in and then stop it going back the direction it came from when the heart contracts and beats. Valves can fail broadly in 2 ways. They can either become narrowed, and we refer to that as being stenosed, so they prevent blood coming into the chamber or flowing through the heart appropriately, or they can become leaky. We call that regurgitant, and that just means that when the heart pumps, some of the blood, instead of going in the way it should go, goes backwards from whence it came, and that makes the heart pump inefficient and often gives patients symptoms.
Hansen Medical was founded in 2002. It is a Mountain View-based company, and it was founded by very visionary engineers as Dr. Fred Moll, Dan Wallace, and Rob Young. The mission of this company is to enhance, with flexible robotics, the ablation in electrophysiology and other medical fields. In 2007, the Hansen Sensei X robot received a CE mark. And with a CE mark, relatively fast, we had installs worldwide. In the meantime, we have over 100 installs worldwide, and the Hansen robot is used by many electrophysiologists. With this very innovative, disruptive technology, the electrophysiologist is enabled to put his finger tip inside of the heart. The catheter, the Hansen robot delivers with the catheter a very stable method to deliver ablation. So that means less risk and more control while doing the ablation. The Hansen technology makes so much sense, not only for the physician who can sit very comfortable in a chair outside of the radiation field. No, on top of this, the patient is not exposed as much as before to radiation.
One of the challenges to us as cardiologists with an interest in heart rhythm problems is that the heart rhythms that we're treating are becoming increasingly complex. And this is a bonus to patients because previously untreatable rhythms like atrial fibrillation or ventricular tachycardia can now be treated with catheter ablation. However, this is associated with an increasing amount of time spent doing these operations, increasing amounts of X-rays used to perform the operations, and lowering success rates because of the complexity of the treatments that we're offering. This is where the Hansen Sensei robotic system comes into its own, because what we've shown in a number of studies, including our randomized trial, is that firstly the X-ray doses used during procedures guided by the robotic arm are actually lower for both the patient and the physician. We also know that physician comfort's improved because the long periods you spend standing by the patient's bed with heavy lead coats on are reduced and your tiredness is reduced, which means that you then can concentrate more on the case and less on the back pain that you have. And the final thing that we still hope to demonstrate is that the accuracy and stability of the catheters held by the robotic sheath are improved, and therefore our outcomes are improved. So I think there are a number of opportunities for the robotic sheath to improve both patient care and physician comfort and safety as well. Patients are already aware that robotic technologies have the potential to overcome some of the frailties of humans, particularly in terms of accuracy of movement. And so patients respond very positively to the idea of you using a robotic arm or sheath to help you guide this very complex procedure. The patient that we're doing an ablation on today is a patient who's got long-standing persistent atrial fibrillation with a lot of symptoms as a result of this. And so he's going to have a relatively long, complex procedure. And I'm particularly happy about doing it with the robot today because not only do I think that it's going to reduce radiation to him and me, also allow me to concentrate through the entirety of the case, but I've also got quite a sore back today. And so the prospect of not standing with a very heavy lead shield by the patient means that it's now going to be possible for me to do this procedure rather than cancel it for a few weeks later when my back pain has improved.
The AF work that we're doing at London Bridge Hospital has certainly grown since the Hansen robot was introduced here. The public awareness of AF and AF treatment is steadily growing throughout Europe at this time, and I think that can only continue. The main benefit of the Sensei robot is to the cardiologists. They are expected within arrhythmia treatment to spend a great deal of time in the catheter laboratory. They are on their feet, and previously there's also the underlying concern about irradiation. The robot allows them to be more relaxed, it removes downside risk to some degree, and it also takes away the physical exertion which can only denigrate performance over a period of time. At London Bridge Hospital, we're pleased to have made the investment. I believe that our cardiologists feel they're being supported. I feel that the patients are attracted by this cutting-edge technology, and it has kept the focus on London Bridge as a leader in cardiac services.
With the Hansen Sensei X robot and the Artisan catheter used in combination, Hansen Medical is changing the landscape of ablations in electrophysiology. It delivers a procedure with more control and accuracy. And with this disruptive technology, we think that's just the beginning.
There are a number of risk factors for cardiovascular disease, and these include, as we talked about before, diabetes mellitus, but also such things as smoking, high blood pressure, high cholesterol, and also, certainly before the menopause anyway, being male.
The focus to date within healthcare has likely been on saving lives in hospitals and acute services. The NHS has made fantastic progress, leading to more and more people surviving cardiac events and living with coronary heart disease. The Department of Health is now urging the NHS to focus on what happens after these patients leave hospital and ensure that all patients receive high-quality cardiac rehabilitation to cut the risk of future cardiac events. Now, this requires a culture change to move the focus of health and social care services into a lifelong relationship with patients. We hope this programme will go some way in helping healthcare professionals in the NHS and the wider healthcare sector to broaden their skills and expand their roles and scope of practice within heart and cardiac care. I'm Doug Grant, and you've been watching Heart of the NHS.